Okay, right. So welcome to the third session on infertility, and I think in total the 33rd session I've been conducting. So now, as you all remember, we looked at two main areas: male infertility and female infertility. Just to go over the statistics, remember, 35% of infertility is due to 65% of the 35% of the infertility is due to male factor infertility, right? And then 65% of infertility is due to other factors, out of which about half, 50%, that is about maybe 32-33%, is due to female factor infertility. And the rest, roughly 1/3, is due to unexplained infertility. Okay. So therefore, now we are coming to the third portion, which is unexplained infertility. And then today I will also conclude for the whole thing by talking to you about assisted reproductive techniques. Okay. So then today's lecture, we will conclude infertility once and for all. Right. Now, let's unexplained infertility is a very small portion, so I'll be able to finish that quickly. What does unexplained infertility mean? Basically means not that there is no reason for a person's infertility. It simply means that our conventional methods of finding out or investigating them has not really found a cause, right? Definitely there has to be a cause, but it has not been found by our conventional methods, because in the male and the female, there are so much of things that we do not have tests for, or we do not have ways of investigating. For example, we do not have very good methods to evaluate the tubal transport. We do not have very good methods to look at the tubal environment. We do not have very good methods to find out whether the sperms themselves are inside, they are normal, whether their acrosomes are normal, whether their motility is capable, whether the implantation mechanisms are in place, whether the receptors react with each other, right? So all these mechanisms, these molecular level problems are not being detected. So therefore, there will be a reason, right, which we cannot detect. So unexplained infertility means once we have done a conventional set of investigations, right, for the male as well as the female. For the male, it is a seminal fluid analysis, and that is normal, shall we say. And for the female, we have checked whether she is ovulating, whether we have checked whether the genital tract is intact, we have checked whether the womb is normal, we have checked whether the ovaries are normal and they are ovulating, we have checked that the tubes are working by our test, which may be a laparoscopy and dye or HSG, right? And we have done all that, and we have found that the male and the female are normal. And now we do not have any possible explanation from our that why the infertility is there, right? So therefore, then it is called unexplained infertility. And then comes the question, what do we do? Nothing to do with the male, no problem with the female as far as we can understand. And now what do we do? So then next comes, okay, we need to talk to them. Look, we have examined the male partner, we have examined the female partner, right? In the history, everything is normal, and therefore we have to arrive at a diagnosis of, yes, you all are infertile. However, we do not have the explanation as to why you are infertile. Okay, so most couples are not very happy to hear that, right? Because there does not seem to be a treatable cause for this. So therefore, we need to counsel them very much as to what our plan is about unexplained infertility, right? Right. So now where do we go from there? The first thing that we do is to talk to them as to what to do. The commonest now approach to this problem, right, is the first is we need to definitely talk about what? About their diagnosis. So you have to tell them, number one, there may be a cause that we have not found, right? And therefore, that is the reason that we call it unexplained. Our present day conventional investigations have not found what the problem is. Do you understand? And what are the things that may cause unexplained infertility, right? Number one. So if you look at the reasons, you can go from the ovaries to the environment, to the endometrium, and then possibly the genetic male factors and the factors in the embryo, and all this we can talk about, right? So now let's talk about the ovarian factors. What are the causes, if you ask, okay? What are things that can contribute to unexplained infertility? For example, in older women, the poor ovarian reserve, right? Because there are less number of oocytes which may be normal. Sometimes the quality of these oocytes may not be normal, right? So these are the things that the oocytes themselves may not be very normal, or the quality may be poor. So those might contribute some, but because we have no way of actually assessing the oocyte quality, right? So those are the ones that may cause unexplained infertility. Then inside the cavity in the peritoneum, there may be very mild endometriosis or something that may not have been detected. There are no clinical symptoms. Even on laparoscopy, we may not find those, but there may be all this. And also there may be things that are altered there, different kinds of the chemical environment, macrophage activity, different things may be altered there. So therefore, these things cannot be measured or tested during our routine test, right? Inside the endometrium also, there may be different cells that may cause harm to the embryo itself, right? And there may be abnormal proteins, abnormal antibodies, all that may be secreted within the endometrium itself, which cannot be measured, right? And the male factor, the acrosome reaction may be changing. There may be different, the binding of the oocyte, right, to the oocyte, and penetration through the zona pellucida of the oocyte. Those may also not be normal. And of course, in the embryo, there may be unknown genetic and chromosomal abnormalities. So these are the things we cannot really find as to what the causes are. Do you understand? So in your mind, what you need to understand is, yes, we know the parameters that are there for fertility or infertility that can be explained. And these are the parameters which we are not able to know. So in summary, there may be problems with the eggs, right? There may be problems with the sperms. There may be problems with the peritoneum, right, inside the tummy. There may be problems with the endometrial cavity, and there may be abnormalities in the genetic setup of the embryo itself, right? So those are the subtle things that we may not be able to find. So these may be the causes of infertility. So now, what do we do about it? Number one is expectant management. So this has been found to be one of the best ways to approach this problem. Now remember, children, that I told you that infertility in a normal couple is, we start investigating after 1 year. So infertility means if the couple has tried for 1 year and has not conceived, then that is, we term it as infertility, and we start our process of an investigation there, right? Expected management is what? We counsel them in unexplained pregnancy. Okay, let's wait another year, right? So you wait until the end of the second year. in unexplained infertility to see whether they can conceive naturally, right? Which has been found to be in par with unstimulated intrauterine insemination. What is unstimulated intrauterine insemination? If you give them check for eggs, right? And then you take the sperms and after ovulation, check by various means, maybe by checking the LH surge by special kits, right? Or tracking the eggs or follicles by a scan and see they have ovulated, and then you put the sperms in by, after cleaning up the sperm, you put them into the cavity, right? That is an unstimulated intrauterine. There's no difference, right? In some studies, there's no difference between stimulated intrauterine insemination. What does that mean? You give medication like clomiphene citrate or letrozole, you stimulate the egg production, and then you give injections or HCG for the egg to come out, and then you do intrauterine insemination. So in most studies, even when you compare intrauterine insemination stimulated cycles with expected management, the results seems to be the same, especially in the first year, from the first to the second year, and then till the end of the second year, right? So therefore, if we can counsel the couple properly and say, look, if we wait for another 1 year, right, and you engage in sexual intercourse frequently or 2 to 3 times a week, right, try to conceive naturally, there's a good chance that you might conceive naturally. So expectant management has been one of the mainstays of management of unexplained infertility. You all understand? Right? So that is one thing we need to talk to them about. The second thing you need to understand is, when is this more effective? Just wait another 1 year without doing anything, right? If the female partner is, the age is less than 35 years, expectant management is effective. Second thing is, if the female partner has had children before, right? So the expectant management may be also beneficial, right? And so these are the factors that influence this. And also, if they have been trying to conceive for about 1 to 2 years only, right? And they have come very early in their attempts of conception. So if they have referred themselves immediately, say after 1 year of trying, and then expectant management has been found to be more successful than, say, a woman or a couple coming after 5 years of trying for conception. You all understand? So the factors affecting the success of expectant management are what? Younger females less than 35, if the female has had children before, and third thing is, if the period that they have been trying is a lesser amount, right? Hold on, sorry. Right. So expectant management is one of the things that we need to talk to the patient about, right? Okay. The second approach is, now what happens is, now the couples who have tried for 1 year or so, or maybe more, they will come to you and you do the examination on the male and female, and we do not find anything wrong. And then when you say, look, let's try to wait a bit more, they might not be very happy with that. Because when they already seek medical treatment, they want a medical solution to the problem, right? And they will ask you, doctor, we are tired of waiting, right? We have waited so long, we have been trying so long. Is there anything else that you can do? So one of the options then comes whether we need to go for intrauterine insemination. However, it has been found, even if you go for sometimes intrauterine insemination, the success rates may be the same. However, if you go for selected or you go for stimulated or controlled ovarian stimulation cycles, then sometimes the success rate may be slightly higher than expected management. What does this mean? Number one, you need to give them a drug that induces ovulation. There are many. There's clomiphene citrate, right, which is a selective estrogen receptor blocker. What does it do? It just blocks the estrogen receptors in the brain. And then the brain thinks, okay, ovaries are not working. So they put out more FSH or gonadotropins, and that stimulates the ovaries. The problem is it can cause multiple eggs to grow, and it can cause multiple pregnancies if it becomes successful. Then we track the egg to see whether it is of a certain amount, 1.8, 1.9, or 2 centimeters. And when it's mature enough, we give a trigger, and the trigger to cause ovulation, that is human chorionic gonadotropin. It imitates LH because the LH surge causes the egg to come out. So we give a trigger. And then 36 to 40 hours later, once the HCG is given, the egg comes out. And then we will take the sperm, ask the man to give us sperm, wash it, get the most motile sperm with a small tube, plastic tube, place this best sperm we can find into the uterine cavity, right? And we think that the sperm will swim up with patent tubes, and because the egg would be already waiting at the end of the tube after the ovum is picked up by the normal, hopefully normal tube, and then conception can occur, right? So these are intrauterine semen. So what are the medication we can use? We can use clomiphene citrate, 50 daily, 50 twice daily, or 100 milligrams daily, 150 milligrams daily, right? A maximum of up to 200, but normally 150 milligrams daily from the third day to the, so on the second day to the 6th day, right? And then we can wait for another, say after day 8 or day 9, sometimes day 11 or 12, to see whether the follicle is growing by doing ultrasound scan. And then we give human chorionic gonadotropin when it's mature enough or large enough to induce ovulation, and then that can, then we perform the intrauterine insemination, right? What are the other one? We can use letrozole. Letrozole, we can use about 2.5 milligrams daily. Then you can increase, if there's not sufficient ovulation, 2.5 milligrams twice daily, right? And a maximum up to 2.5 milligrams 3 times daily from day 3 to day 7. So that is also what the advantage of letrozole is. It most of the time it gives unifollicular ovulation, one egg, while clomiphene citrate might give us several. Of course, if these two are not very successful, then we can use gonadotropins. FSH can be recombinant or other types of FSH to stimulate ovulation, and the same process will go on for us to do the intrauterine insemination, right? So these cycles of IUI may be slightly better as far as the success for than expectant management itself or unstimulated IUI cycles. As I explained earlier, unstimulated IUI cycles, we don't give clomiphene or somewhere. We just wait for the egg to grow, right? And we wait for it to ovulate, and then we detect ovulation by checking out the LH surge biochemically. And then once we detect it, there are urine kits that can do it. Then we do the intrauterine. Those are unstimulated, right? We don't give any ovulation stimulatory agents. Unstimulated IUI and expectant management, same results. If you compare expectant management with stimulated IUI or controlled ovarian stimulation with HCG and IUI, that is slightly better than either the unstimulated and the expectant management, but the results are not that great, right? So that is something which we can offer at this stage for unexplained infertility, right? So what is the next thing? Next thing which we need to understand, right? The next step is in vitro fertilization, right? And when we offer in vitro fertilization, the chances of achieving a pregnancy for patients who are having unexplained rate is far greater than both expectant management, both unstimulated intrauterine insemination and stimulated intrauterine insemination, right? As you all understand, what is IVF, that you'll have to understand. What is IVF? Is that you give, which we'll speak about in the next discussion, right? That is the next topic which we are going to do. Is that, first of all, we will stimulate the, we will get the eggs out from the female, right? Do the insemination outside and then put in the embryo into the female, right? So this IVF gets far more results, better results than all the other things that we mentioned. That is expectant, unstimulated IUI and stimulated IUI, right? So this is basically how we go about this. If you want to discuss unexplained infertility, this is the pathway that we offer these patients, right? So it's a very simple topic. So therefore, one of the main things that you need to understand is the reasons that there may be, which we do not find out from our conventional investigations. To expectant management is a very important step in the management, that is from the first year to the second year, because remember, if we find something, we start doing something about it. But here we can wait another year, especially if the woman is less than 35, if she has had children before, and of course, if the period of infertility is short, right? The success rates are high. And then you go from stimulated or control ovarian stimulation with HCG, trigger, and intrauterine inseminations. And from there onwards, you can go on to in vitro fertilization, right? So these are the steps for the treatment of unexplained infertility, which is quite straightforward. Is that clear, children? Right? Any questions that you want to ask? Because we will switch to the next topic, which is also not a very long topic, that is assisted reproduction. So before that, do you all have any questions that you want to ask me? Please do. Anything? No? Right, okay, fine. So the next step, I just want you to understand the principles, children, nothing else, right? As to how it happens, because this is something that you need to understand, because this is something that you are going to come across all the time, right? In vitro fertilization or advanced assisted reproductive techniques, right? So 1976 was the first time in vitro fertilization was performed. Okay, so the first IVF pregnancy was an ectopic. Okay, and then this was in Britain, UK, and then this continued, and then the first successful IVF pregnancy born was in 1978, and the baby that was born was called Louise Brown. If you Google Louise Brown, right, you will find her. She is now 44 years of age, right? And she also has her sister was also born, I can't remember her name, by IVF, I think 2 years or 3 years later, to the same parents. And that sister, I think it's Nancy Brown, I'm not sure, gave birth to the first natural child born to IVF baby. Okay. I don't know about Louise Brown. I'm not really sure, but I think the first, she may have had children, but the first child that was born to an IVF baby, that is the baby's baby, okay, was to a sister, right? So, but that is 1970. So that is the first IVF then. After that, it spread all over the world. And then in 2000 and I think 2018 or 2020, the remaining person, I think the physiologist, right, was awarded the Nobel Prize for an innovation which changed the world, medical innovation. That was 2020, I think. Just Google it and see, right? And the rest of the, there was a physiologist and an embryologist and a gynecologist. All three got together to do this in vitro fertilization. So there was only one remaining person, and he got the living person, and he got the Nobel Prize in, I think, 2020 or 2018, I'm not sure. Okay. So this is in short the history of IVF. So it has developed a lot since then. It has developed a lot and lot. And the most important innovations of all that from the beginning, right, are two things. Number one, the possibility of doing ICSI, intracytoplasmic sperm injection. What does that mean? Even if there's a small sperm head with the male DNA in it, it can be injected into the egg, right? And a baby can occur. That is ICSI. Second thing is the possibility of doing pre-implantation genetic diagnosis. Before the embryo is put in, you can check the genes for that, right? And there are many, many other innovations that have come, and the success rates are going up, right? And therefore, now IVF and assisted reproductive techniques are very, very commonplace. Usually in some countries, 1 in 7 couples might require it, right? So therefore, a lot of in vitro fertilizations are done. And there are millions and millions of babies, I think more than 1 million babies or more than that, who have been born by IVF. Maybe amongst the audience also, there may be children, right, who are listening to me now, who have been born by IVF. So remember that, Louise Brown. I think the gynecologist's name was Steptoe. Steptoe, yeah. I can't remember the other names, but just look up, all right? A history is interesting. Okay. Now, to monitor all these, each country should have a authority. In some countries called Human Fertilization and Embryology Authority, right? Different countries will have. And some countries may not have regulatory bodies. So anybody can do anything they want, right? In our country also, we do not have a fully established authority. Some laws are being put to place, some are being formulated, some laws are being drafted, but still we do not have a complete authority to monitor these, because this is we are dealing with human embryos. So it's all these really need to come into place to make it safe for the parents, for the child, right? To make sure that malpractices do not occur, right? However, we do not have at the moment a very strict human embryology, human fertilization and embryology authority as in some countries, right? But all the countries that are, the IVF is very well established. These authorities are extremely powerful, extremely strong, and they keep a very, very close watch over what is happening at each center. And these will provide independent reviews of each center. Will shut down the centers if they are not aligning with the standards of care, and will also give independent success rates of each, and they carefully monitor these centers, right? Which is an essential part of good practice, right? So hopefully in Sri Lanka also, we will have that someday, right? Now, if you look at the total indications for IVF, it can be broadly categorized into female factors, male factors, and factors affecting the couple, right? Why do we need IVF? Now, if you look at the female factor, if the tubes are not there for some reason, right, then of course she can't conceive naturally, so she needs IVF. Okay. If she has very severe endometriosis, however much you operate, however much you do a very good job, if the tubes are absolutely stuck, right, and then of course the best way is to clip the tubes so that the association between the peritoneal cavity and the endometrial cavity is terminated, so that the chemicals don't get into the endometrium, and then put the embryo from outside to the endometrial cavity. Do you all understand? So very severe endometriosis, right, with tubal distortion, also with very bad intraperitoneal chemical environment is a reason for IVF, right? Of course, if there's a small ovarian residue, or if the woman is very old, right? That is very old in the sense for fertility wise, okay? Say over 40 years of age, if they're 45, some wish for babies even after 45, 50, you would have seen women getting pregnant at sometimes 60 years of age, 55 years of age, then of course IVF remains the only possibility. And if she has had premature ovarian failure when she was young, right? And also now what is happening is lesbian couples, right? The partners are female, they are couple, and they want a child and they want to conceive. So this is allowed by law in some countries. So the lesbian, there's the only option for a lesbian couple to get one of them to get pregnant would be a assisted reproductive technique with donor sperm, right? Or sometimes in other countries, if a single woman wants to have a baby, doesn't want a partner, doesn't want anything to do with a male partner, right? Wants the baby only. Some countries will allow her to have an IVF to have a baby on her own. Okay, so these are the indications as far as the male factor is concerned. Okay, in the male, if she has azoospermia, then it allows them. Then of course the only way would be IVF, maybe with if sperm can be taken from biopsy, then ICSI can be done. If he has no sperm production with donor sperm, then of course that is one possible, right? Then sometimes if the male has ejaculated dysfunction, then of course also if you cannot make a woman pregnant, then of course you have to go for IVF, right? And then medical, if there are medical problems like malignancies, chronic renal failures and all that, and if the man is unable to have an erection or make a woman pregnant, then of course IVF also is an option. Here also gay couples come into play. If a gay couple wants a pregnant, they can use a surrogate mother, right? Have a baby, right? They can use one of their sperms, but they need a surrogate mother, right, to produce a child, so they can have the child. So that is also one indication for IVF, right? The next is, if you consider the couple, right? If they have been long time, like unexplained infertility, long time, then of course IVF is an option, right? We are not talking about the male or the female factor, but for unexplained infertility. If they have genetic disorders, right, which causes with a very strong family where the predisposition to these genetic disorders are very high, then of course IVF becomes a possibility with somebody else's sperm or with somebody else's ovum, right? And then if there are anatomical abnormalities in the male or the female, right? And all these things, right? Some congenital anomalies in the male or female, right? These will cause them to go for IVF. Do you all understand? So these are the reasons that the men, the woman, or the couple might go for primarily for in vitro fertilization. Do you all understand, children? Right? Okay. So now let's look at the whole topic very quickly. The first most important thing is counseling. And what are the types of counseling? Now, first of all, the medical counseling. So initially the couple comes and a professional medical person, right, or a specialist will look at their problem and decide, okay, or try certain other techniques and say, okay, now I think you need in vitro fertilization or advanced reproductive technique, right? The second thing is there should be a counselor, right, who is a professional counselor who is going to take them through the whole process. It has to be a trained counselor, right? The medical professional cannot do that. There has to be a trained counselor in these centers who will take them through the process, the legal process, whether they are suitable for this, if there's financial constraints, if the government is involved, what the rules and regulations are, what are the possibilities. They will also take them through the possibility of adopting or having foster care, right? So all these, this council will take them through all these issues, because these are very, very complex issues, highly individual. Each couple has their own problems, so they need to solve those. And of course, come to a conclusion as to whether this couple is suitable for IVF, and then emotionally, as well as legally, as well as all that. And there are a lot of binding things that needs to be done. You can just go for IVF. So there are a lot of legal papers to sign, all those, where they will be counseled according by a professional counselor. And of course, then if there is a genetic counseling also comes in play, because if they have diseases that may be given to the child through their genetic setup, right? Those also will need to be looked into to make sure that the baby does not inherit these diseases. So that also the woman and the child must be told, okay, there is a risk about this, so they can take the decision process. Do you all understand? So the first process is counseling children. Medical, then there's a professional counselor, and there's genetic counseling. Those are the three important types of counseling that you need to go through if they want to go for a in vitro fertilization, right? Then let me take you through a IVF cycle, right? The first thing in an IVF cycle, children, is that the normal pituitary, ovarian, this cycle cannot go on, because we are doing everything by controlling everything. So the woman cannot produce an egg here, then 10 days later another egg there, next cycle, that is not possible, because this is a assisted reproductive cycle. Okay, so the first thing that must be done is complete pituitary suppression. Okay, so now the pituitary, which is in the brain, okay, must be suppressed, and or the pituitary should not be, or the GnRH, right? The must be suppressed. And how is it done? We have to give two types of medication to suppress this. The first type of medication is a GnRH agonist. The hypothalamus produces GnRH. And to stimulate the pituitary, it goes in a pulsatile manner, pulses, right? So if you give GnRH agonist, what happens is, in a continuous dose, initially the agonists are peptides, okay? These peptides will go and bind to the receptors, GnRH receptors. And initially, if you give an agonist, it will stimulate it. So initially there will be a flare of FSH and LH, right? And then once the flare is done, because if there's continuous agonist action, then suppression occurs. However, for complete suppression of the pituitary, it might take about 1 to 2 weeks. Okay, so if you are using GnRH agonist, initial flare and then later suppression because of the continued agonist action. That takes time. So the takes time for the cycle to start. Is that clear? And the next option is GnRH antagonist, where there is antagonism and blockage of the receptors. And that is short because there is no flare-up. It immediately blocks the receptors, right? And the cycle can commence earlier, right? So do you all understand? So the GRA normally therefore the cycle can start earlier. So what happens is initially it is complete pituitary suppression. Is that clear, children? Right? The next step is what we call superovulation. Right? Superovulation is now once everything is suppressed, everything is base level, ovaries are completely inactive, then you start to give FSH, right? And when you give FSH, now here for clomiphene, letrozole, there's no. Right? So you have to give large doses of very stimulatory things, which is called what? We have to give gonadotropins. And gonadotropins are FSH, right? FSH can be human menopausal gonadotropin. It may be or recombinant FSH. These are things that have been manufactured externally, right? For the moment, most of the things in the this purified this recombinant FSH is done by a Chinese hamster line. Okay, it's from a Chinese hamster. Okay, so this recombinant initially, right? So therefore, so you can have different kinds of FSH. They can be human menopausal from menopausal women, right? There can be purified FSH. There can be recombinant FSH, right? Right. So all these are used to stimulate the ovary. So what happens to the ovary? It gets a lot of stimulation for FSH and lots of follicles starts to grow. Okay. So you have superovulation. Now, once you start the ovarian stimulation, you have to monitor it to see how the eggs are growing, right? You can monitor it with certain kinds of hormones, right? Like estrogens, different kinds of hormones. You can monitor it by doing what? Doing ultrasound scans. So you do ultrasound scans, and then you monitor the maturation or monitor the ovarian stimulation. Is that clear? However, just because the eggs are getting monitored, right, and the eggs are growing, does not mean that the oocytes are going to achieve maturation. So there must be oocyte maturation also. It can mature current, just like teenagers. Sometimes, you have like superovulation, a lot of, things growing. But for you all to mature, there must be other things. So that's the same with the oocytes, right? So the oocytes are getting stimulated and they are getting growing. You monitor them, but at the same time, you need to mature these oocytes. For oocyte maturation, right, you need LH, luteinizing hormone. However, the amount of LH, now LH has been completely suppressed by our pituitary substance, no LH. So therefore, we need to give from outside LH or its analogs. And what is the cheapest analog which we have? We have HCG, where one of the subunits are equal to that. So therefore, commonly used, so you can use LH if it is available, which is a bit recombinant LH is there, but it's very expensive. But the most commonly used oocyte maturation agent is HCG, right? And it is used in certain doses, and therefore, then the final trigger means the HCG is injected, right, before oocyte retrieval, maybe 34 to 36 hours earlier. So the final HCG is also given, and then the oocytes are thought to be good for harvesting. Is that clear, children? right? So then, now up to now, you all clear? You have counseling, you have pituitary suppression, right? You have superovulation by using FSH. Then you have to mature, you have to monitor the oocytes, right? Monitoring. Then you have to mature the oocytes by giving HCG. And then the final HCG is given for a trigger. And then 34 to 36 hours later, before the eggs come out of the ovary, right, you have to start to collect them, right? And the next one is what? We have to do oocyte retrieval. And how do we do oocyte retrieval? In a transvaginal probe, there is a needle on the probe itself, right? And it is put into the fornix so that the ovary is, the stimulated ovary is very much near the posterior fornix. And the needle is slowly advanced into the follicle under ultrasound guidance, and the fluid from the follicles sucked and then collected into a petri dish, right? Immediately, so while this is done, immediately the theater or the patient is on a theater table, right? And actually there's a window lighting where the embryologist is on the other side, right? Because the ova must be immediately transferred onto the fluid must be immediately given to the embryologist. The embryologist will do what? They will look at it under the microscope and quickly take the eggs that are the oocyte that is floating in the dish, right? So now oocyte retrieval is a surgical procedure, right? In the sense, a mini surgical procedure where the aspirations are done. It hardly ever has any specific complications unless otherwise a bowel is injured sometimes, but it's just a prick, right? Can be done under sedation, right? Or even without sedation, but most of the time it's done under sedation, under sterile conditions, of course. And the oocytes must be immediately given to the embryologist for analysis under a microscope. And then the egg must be chosen from that fluid and then put into a petri dish or a culture media, right? So-called tube. Okay. The next thing is, once the oocytes, then once the collection is done, then what happens is insemination and fertilization. So insemination can be done with fresh sperm, can be done with thawed frozen sperm, right? And the sperm is put onto these oocytes, which are mature oocytes. And if sometimes if there's only a few sperm which has been retrieved by any biopsies, then ICSI, intracytoplasmic sperm injection, also can take place for the insemination, right? Once that is done, then the next day, right, again these dishes are checked to see whether whether fertilization has taken place. And how do we judge that? Inside the egg, we start to see two pronuclei, right? One set is from the oocyte and the other is from the male sperm. Because if the acrosome reaction has taken place and the sperm has been, the DNA has gone into the nucleus, so you can see two pronuclei, at the one from the oocyte and one from the, which confirms normal fertilization. Do you all understand? If the oocytes are not fertilized, those are discarded and you keep only the ones that have been fertilized, right? And then the next one is embryo transfer, right? You can have cleavage embryos, right? That can be transferred on day 2 or day 3, or you can transfer them at the blastocyst stage, which is day 5 or day 6, right? So transfer is, what is done is, under sedation is not necessary, where a very thin plastic catheter is used, right? Transcervical is inserted, it's a polypropylene catheter, right? And ultrasound guided the catheter is inserted, make sure that it does not hit anything, because if it hits something, especially the fundus, you can have small myometrial contractions, which will cause or prevent the egg from implanting. Okay, the embryo from implanting. So it should not touch the fundus. So it is advanced into the mid cavity, and the embryo is deposited onto the endometrium, right? Of course, there are certain ways to prepare the endometrium, and the endometrium must be of certain thickness, but then the embryo is deposited there. So that is called embryo transfer, right? So once that embryo transfer is done, and what is the next step? You have to use, once the embryo transfer is done, then the next is you have to use luteal phase support. Why? Because in a normal pregnancy, the corpus luteum will support the pregnancy. Now here, there is no corpus luteum, right? Because we have completely circumvented that, right? We have just taken the eggs out. And therefore, you need to give luteal phase support by progestogens, right? So different kinds of progesterones will be given for luteal phase support, right? HCG can be used, right? Different preparations, different kinds of progesterone, right, is given for luteal support. Even sometimes a combination is given. So different kinds of estrogen, progesterone, HCG, all sorts of different combinations are given, and basically all these are to support the growing embryo, right? Once that is done, right? Once that is done, the next step is, of course, this goes on till until the placenta has established itself, right? And then once that is done, it goes on, and normally on the 16th or the 17th day after embryo transfer, right, an HCG, serum pregnancy test is checked to see whether the implantation is successful. Then, of course, the HCG will start to become positive on the 16th or the 17th day after embryo transfer. Okay, and then so on after that, right? Then also, then she goes back to a normal sort of antenatal care, right? Do you all understand, children? So this is a normal in vitro fertilization cycle, which you all need to just understand the basics. Got it? Right? So there is a subspecialty which is called there are subspecialists for infertility, which then, and it's always a team. You have a gynecologist, right, who performs a certain task, embryologist who performs very specific tasks, right? And in combination, there's a counselor. So that is why IVF normally should be done in centers where IVF is performed as a team and a highly specialized team. And definitely, although it might not be very well regulated, in some countries like in Sri Lanka, IVF needs to be regulated by a very independent authority, as it is done in well-established centers in the world, right? So these are the things that you need to do. And what are the other things you need to do? The embryos can be frozen for years and years. So all the extra embryos can be frozen. So if there's a problem, say a malignancy or anything with the venous, sometimes the eggs can be retrieved, embryos can be made, right? And the best way, sperm can be frozen as well as embryos can be frozen very well. Sometimes they can be thawed out 20, 30 years later, right? 30 years later also, you can implant them or transfer them and have successful pregnancies. Oocyte freezing has not been very successful, right? So therefore, there are problems with that. So of freezing, but however, it is being practiced for women who are to undergo maybe due to cancer, who are to have oophorectomy. Then these oocytes can be frozen, but also the ovarian tissue can be frozen, but it is less successful for the moment than freezing an embryo. So the embryo freezing has advanced a lot, right? In certain where embryos can be frozen very, very successfully and even kept for 20, 30 years or more, right? So that's called embryo cryopreservation, right? So those techniques are all. Sperm also can be successfully frozen, right? And the other thing you have to know is the embryo, especially the if it is frozen in the cleavage stage, day 2, 3, the success rate is higher than to freeze it in a blastocyst stage, right? So that is usually when you thaw the embryo, it is best if the embryo has been frozen at the 2nd or the 3rd day, right? So these are things that you need to understand about advanced assisted reproductive techniques. So basically that concludes, you all just need an overview of the children. I just wanted you all to understand. So basically that concludes all the lectures on infertility. Okay, so I have covered female, male, I have covered unexplained infertility and assisted reproductive or advanced in vitro fertilization techniques, which you all just need to have an overview of what is happening. Okay, right. Anybody has any questions? No questions. Any questions, children? Okay. Okay, one question. In IVF, until when do we need to support with progesterone? And until sometimes this progesterone support goes on until delivery, right? But initial support is extremely until the placenta is separated. Definitely beyond 12, 14 weeks. Okay. Anything else? Okay. Oh, another question. Okay. How many embryos do we plant? Right. Now, I forgot to touch on that. The success rate rainbow of IVF usually less than, if the woman is 30, 32 years, 33 years, the success rate is around 30%, right? 20, 30%, 30, 35%. Some centers will say they are 50%, right? 60%. I don't know how fruitful those are, but usually it is thought to be about 30%. If IVF is done with the AON embryos, AON eggs, between 40 and 45, the success rate is about 5%. Okay. So sometimes when there's advanced stage, most of the centers would suggest donor eggs, right, to go in with advanced reproductive techniques, right? So therefore, and of course, there are different kinds of IVF which you need to be aware of, right? Number one, you can have donor eggs, right? And the partner sperm. So it is IVF with donor eggs. Then there can be IVF with donor sperm, right? Which the partners, if the sperm cannot be retrieved from the partner, you can have IVF donor sperm. Then you can have IVF with intracytoplasmic sperm injection, where only the small amount of sperm has been found in the male, and just maybe just a sperm head, and that can be injected into female, right? You can have IVF with surrogacy, right? In some countries it's legal. If the female cannot have a baby, if there's a problem with the womb, or there's the uterus may not be there, or there's an anomalous uterus, but the eggs are there, you take the eggs, you take the male partner's sperm, you do the embryo outside and put it into a surrogate, a womb which is hired, right? So that is surrogacy. Then different, most of the other things have gone out of practice, like there's something called gamete intrafallopian transfer, which is surgical procedure where you put the sperm and the egg right onto the tube to see whether it goes implants at the end of the tube and goes down. Then there's zygote intrafallopian transfer, where you put the blastocyst or not the blastocyst, actually the fertilized egg into the fallopian, the zygote into the fallopian tube, right, for it to go down through the process and implant. So all these, sometimes there's intramyometric transfer where laparoscopically you put it from below if it is not possible. So these things have really, those are very, very rare things that are not really practiced. So the main things are what I told you about, right? And of course, in patients, we also have to talk about adoption and foster care as well for these patients, right? Then the number of embryos. The whole world is moving towards a single embryo transfer. Due to the fact the risks are higher in multiple pregnancies, and the multiple pregnancies sometimes a lot of risk for the patient, because the patients also have problems themselves as well. They may be older, they may be having other medical problems. So single embryo transfer, in some countries are enforced that you are allowed only to do a single embryo transfer. However, if the age is more, say if the woman is over 40 years of age, 2 embryo transfers are allowed, right? More than 2, it's discouraged, right? Because sometimes you end up with 5, 6, 7 babies when you do multiple embryo transfers, right? Because they go in and divide, then you can have lots and lots of babies, okay? Which is highly, very, very risky when you have multiple embryos inside who are growing. It's risk to the mother's life as well as the babies might not come out alive. So single embryo transfer is the standard of the day. However, 2 embryo transfers are allowed if the woman's age is high, because she might not have a successful pregnancy as the age continues, right? So that is the standards for the number of embryo transfers. Okay, so that I think, any more questions? Right. Okay. Is the mode of delivery an LSCS? No, not necessarily. Once the patient is pregnant, then it's like any other pregnant woman, right? There's nothing called a precious baby, right? Every baby is precious, right? So therefore, you have to give total, complete antenatal care and delivery care in the delivery period. So there's nothing about, just because it's IVF, we do not need to go for a cesarean section, right? So therefore, it is normal antenatal care. But of course, the standard of care must be extremely high for every single patient. For every person, the baby is precious, right? So, yes. Anything else, children? Right. So the next topic we will decide later on, right? And we will, do you all have any topics for the next? So now enough of gynecology, we'll do an obstetric topic, I think, right? Yes, sir. So just send in me as the present group, you all can tell me the next topic you all want, right? And anybody who wants have any ideas, please tell me. So I will do it next time. Okay? Okay then. Good night.
Thank you, sir. Good night, sir.
Thank you, sir. Good night.